Thank you, Paul, for the invitation to present today at Cardiovascular Innovations 2020. Thank you to my fellow co-moderators, and more importantly, thank you for everyone who has signed up to listen to our lectures. There is no doubt that this will be the new way of transmitting continuous medical education for the near future. I have been tasked to talk about lithotripsy for vascular access. And over the next 8 minutes, I would like to introduce the concept of intravascular lithoplasty and define the role of intravascular lithotripsy in obtaining vascular access in transcatheter aortic valve replacement. We all know that transcatheter aortic valve replacement has emerged as the predominant treatment strategy of patients with severe aortic stenosis. And it has become apparent that patients treated with a transfemoral approach tend to have a significant improvement in their quality of life and ease of recovery. And even though the trials were not necessarily powered to determine a survival analysis between access routes of transcatheter procedures, there is a signal that notes that patients undergoing transfemoral transcatheter valve replacement may be having an improved survival when compared to those that are undergoing alternative approach. Now, there are numerous alternative approaches: transaortic, transaxillary, transcarotid, transcaval, and transapical, to name a few, that have varying limitations and complication rates. Since less than 10% of all TAVR procedures are performed via an alternative approach, it would require a rather large learning curve and amount of time dedicated to understand these procedures to continue to master them. They have inherent complexities, and in addition, the procedural team gets exposed to higher doses of radiation because of the approaches that are required. The majority of the interventional cardiologists and cardiovascular surgeons are very facile in a transfemoral approach, and as a result, a transfemoral approach may be easier to adopt in general. Now, one of the questions that we have to ask ourselves is whether the higher morbidity and mortality seen in non-transfemoral patients is related to the access that is planned or to the inherent patient characteristics. And more importantly, will a similar outcome be seen if we adopt a strategy to make non-transfemoral patients transfemoral appropriate with intravascular lithotripsy? Lithotripsy has been utilized for more than 30 years in the urological field, in which an acoustic generator focuses sound waves into a solid component, causing renal stones to potentially decay and break. This concept has been adapted now into the intravascular space by allowing for the generator to funnel the sonic waves into the intravascular tree by way of a balloon that has lithotripsy emitters in its body. The balloon is compatible with a 6 or 7 French system, and it can apply pressures of up to 50 atmospheres and direct them into the media or the intima of the arterial circulation, allowing for calcium to potentially break and allow for improvement vessel compliance and significant luminal gains. This procedure has now been evaluated in different observational registries. One of the largest ones is the Disrupt PAD3 observational study, where specifically intravascular lithoplasty was utilized either as a treatment for claudication or specifically for vascular access. If you look at the 17 patients that were utilized for vascular access, you can see that patients had significant calcification of their iliofemoral tree, and after the administration of this technology, there was no evidence of flow-limiting dissections, no perforations, and no other flow-limiting abnormalities, with only a 40% utilization of stents after the procedure. It was learned, though, that the balloons need to be sized to up to 110% of the reference vessel diameter, and when applying the technique to large segments, there has to be at least 1 centimeter of overlap between balloon inflations in order to allow for the appropriate sonication of the area. Now, when we specifically look at the utilization of this technology for transcatheter valve replacement, are rare case presentations, but the largest case series is one of 42 patients that was performed both in a group from Italy and a set of groups in the United States. And in it, we can see that patients who were referred for transcatheter aortic valve replacement who were considered high risk with an estimated STS of around 8%, who had significant peripheral vascular disease, particularly within the common iliac and external iliac component with significant stenosis that would otherwise preclude the therapy of a transfemoral approach, were treated both with the 6 or preferentially a 7 millimeter balloon. The procedure was relatively effective, in which they were able to perform the transcatheter procedure in all of the patients with safe passage of a 14 or a 16 French sheath, which was commercially available. There were no perforations, no limiting dissections, and no use of provisional stenting. And importantly, vascular closure was performed as planned in the majority of the patients, which makes this procedure palatable. However, the number of patients treated with it has been relatively small. I'd like to present a case that we encountered at our institution, in which an 82-year-old woman with severe aortic stenosis, who measured for a 26 millimeter balloon expandable valve, had severe peripheral vascular disease, focused primarily at the level of the aortoiliac bifurcation. When assessing her, it became apparent that her axillary and subclavian arteries were relatively small. So we needed to decide if we were going to treat her through a transaxillary, a transaortic, or a facilitated transfemoral approach. And we decided to proceed with a transfemoral approach. Here is a still frame of our procedure with a predilatation of the left iliac artery. We were able to deploy a 26 millimeter valve without any complications. And our completion angiogram shows that there is no extravasation of contrast and no other evidence of dissections. So this procedure was relatively effective. Now, one of the major advantages of lithotripsy is that it has a relatively low vascular complication rate and low treatment failure. There is also no need for pre-treatment with further stenting of the iliofemoral tree, and the familiarity of the transfemoral axis that our team has. The major disadvantages come through amount of cost, the dedicated equipment that is required, and also the patient selection. Not every patient with severe peripheral vascular disease is a candidate for lithoplasty, and there is a significant learning curve as well. So IVL has emerged as a new treatment option for the management of peripheral vascular disease. IVL allows for the passage of large bore sheaths and devices with small observed complication rates. There is no need to treat with scaffold after the procedure. However, this varies between the patient selection. And although promising, more data is required to determine its role in TAVR, making non-transfemoral patients eligible for a transfemoral procedure. And we still have to answer, how will this impact the outcome in this patient population? Thank you.